Uh, Good morning or good evening as per your geographical location. I'm going to speak on the subject of oral submucous fibrosis. This is a very interesting, at the same time, highly controversial topic, and unfortunately, it is being underrated by most of the healthcare workers, particularly in the Western world. And therefore, I decided to talk on this topic and insist upon it being recognized as a public health issue. Now, I will just like to introduce myself. I'm Dr. Subodh Nanavati. I'm an oral and maxillofacial surgeon. I did my basic dental education from Dental College, Government Dental College from Mumbai, and residency in maxillofacial surgery from the same institute. I've been working since last about 40 years as a maxillofacial surgeon, as a consultant, visiting professor, research director, and also chairman of the Central Board of Accreditation of Healthcare Institutes in Saudi Arabia. I have many publications to my credit, and I have also authored 3 volumes of book titled Handbook of Oral Submucous Fibrosis, which will be published soon. Don't rush to bookstores now to buy these books because they are still under the preparation. What was the today's objective? Why I selected oral submucous fibrosis as my topic? There are 2 reasons. A steady increase in the availability of betel quid. Betel quid is known as pan in India, and areca nuts, along with a concomitant increase in the incidence of oral submucous fibrosis, grants it the status of future global epidemic. The habit of chewing betel quid and areca nut is almost spreading worldwide, and therefore the incidence of submucous fibrosis is also increasing. And that this gives a status of global epidemic to the disease of submucous fibrosis. In the backdrop of ineffective treatment, so far we have no effective treatment for submucous fibrosis, though many conservative and surgical managements are being tried. It is necessary to decode its onset and progression before designing a tailored treatment algorithm. Before we decide a line of treatment, it is very important to understand its incidence, onset, and how it progresses all over the world. Understanding the cultural, social, psychological, and historical background of areca nut and tobacco and the prevalence of smokeless tobacco habits, SLT habits, in the world's different geographic location should enhance our knowledge of OSF. We have to study where this kind of disease has progressed. Now, before we go into details of this subject, for those of you who are not from Indian subcontinent or Southeast Asian country, I would like to define what is the submucous fibrosis. It is an insidious, chronic, irreversible disease, potentially malignant fibrotic disorder. It behaves like stealth aircraft. It comes in slowly, undetected, and drops the bomb. Because many times the patients are not aware that they are developing submucous fibrosis. Their chief complaint in early stage is burning sensation in the mouth, vesicle formation, multiple ulcerations, and inflammation of the oral mucosa. And generally, they feel that this is because of some kind of vitamin deficiency, and they start taking vitamins without realizing that they are heading for a serious oral pre-malignant condition. Slowly, they enter into late and advanced stage, in which case the fibrotic bands are formed in the mouth, particularly in the buccal mucosa, cheek mucosa, and the palate, and slowly the mouth starts closing down. And patient develop what is known as trismus, that is inability to open mouth. And whether you treat them conservatively, in early stages or whether you treat them surgically in late stages, still, sometimes or most of the time, the results are not very favorable. Now, there is a global prevalence of OSF, oral submucous fibrosis. You will realize Southeast Asian countries like India, Pakistan, the Indians in South Africa, Taiwan, Sri Lanka, Myanmar, formerly known as Burma, Bangladesh, Nepal, Malaysia, Singapore, Thailand, China, South Vietnam, Fiji, PNG, Saudi Arabia, Asians in Kuwait, Asians in USA, Asians in Canada, and sporadically among Europeans. So you will realize that significant prevalence of oral submucous fibrosis is almost global. There has been one publication in which a study was done by Dr. Naman Rao, and he came to conclusion that incidence of submucous fibrosis ranges from 0.1 to 30%. In some of the areas in India, particularly state of Rajasthan, the incidence of submucous fibrosis is 30%, and the rest of the areas ranges from 0.1 to 2 to 3%. And this is not only from India. You'll find studies from South Africa, China. All these countries are reporting incidence from 10 to 15%. This is a geographical map of the same incidence. You can see that Rajasthan state here is showing you the incidence of over 30%, while the rest of the areas in the country are showing incidence ranging from 0.1 to 17%, 20%, like that. Now, what are the basic reasons, the cause or the factors which are responsible for popularity of areca nut and bitter nut chewing in Indian population? Social acceptability. Indians believe in divine origin of areca nut because areca nut has been part of many religious and social occasions. In absence of presence of God's idol, they place supari or areca nut and it represents God for them. Religious beliefs. Areca nut is considered part of food offered to gods. In the absence of any visible idols of gods, areca nut plays a role of offering to God himself or herself. People also believe that areca nut has got many medicinal properties, and it has been described as an astringent, mouth freshener after meals, taste enhancer, purgative, and intoxicant. Addiction. Areca nut influences the brain. Quid, that means betel quid or known as pan, with areca nut is used as a mildly euphoric stimulant for males because it contains relatively high psychoactive alkaloids. In modern world, you can call it pan as an ancient Viagra tablets for males. Now, if you go through the incidence of submucous fibrosis or prevalence, the number of gutka is areca nut containing tobacco. These are the ready-made preparations available in pouches or sachets. Consumption is rising very rapidly because before 2000, the frequency of OSF, that means frequency of oral submucous fibrosis in patients visiting dental surgeons was 0.2 to 1% in the age group of 45 to 54 years, while sex ratio was 1 to 3, male to female. After 2000, When the sachets started becoming available, there has been a 2 to 5% jump in OSF incidence in the age group 15 to 35 years. And this has made India number one country in the incidence of oral cancer. Earlier, before these sachets were introduced by manufacturers or industrial establishments, pan had to be made with your hands. It was messy to carry around and it lacked modern packaging. Now you have an industrial version of what was earlier traditional custom. Now your ready-made sachet, you can put it in your pocket and move around anywhere you want. Whenever you feel like, you open sachet, put contents into your mouth and enjoy tobacco and areca nut together. And this manufacturing was started first in India, and they marketed this pan parag or pan masala or gutka as to prepare a convenient anytime, anywhere substitute for pan and give respectability to a habit that was considered wrong in the images by gentle. Because when you eat pan, you had to spit out the red saliva that collects in your mouth. So most of the educated and highly qualified people were not ready to accept pan as their regular habit. And to replace pan, this gutka was introduced. What are the reasons why young kids or children younger generation becomes addicted to tobacco and areca nut? First is easy availability. It is everywhere, around the corner, on the street. There are plenty of shops where areca nut and tobacco gutka is available. They are cheap. They are not very costly. Parental habits. The father and mother or grandpa or grandfather, somebody is eating gutka regularly. The peer pressure on the children, and they also start eating gutka. Advertisements. A lot of advertisements are available or they are posted in newspapers, TV, and all other social media. Peer pressure. The parents or grandparents, they insist that tobacco and areca nut is very good for health and you must also start eating, and that makes younger generations to start eating gutka. Universal availability. It's available everywhere. You go to any part of India or any part of the world, it is available. If it's not manufactured locally, it is imported from Southeast Asian countries. School friends, they insist that you must have gutka once in a while. Endorsements, lot of programs or the award functions of Indian films like Bollywood or Hollywood are being endorsed by these industrial establishments manufacturing pan parag or pan gutka. What is the biggest hurdle in tobacco habit intervention? It's ignorance. People are not aware of the harmful effect of chewing areca nut or tobacco for a long duration. And another important thing, that is, whenever a patient who has habit of chewing areca nut or tobacco goes to a dental surgeon or any person who is specializing in the mouth diseases, they may see a small lesion in the mouth, but it may represent or it may look like a malignant lesion, or sometimes it so happens it is other way around. A malignant lesion in the mouth may look like a benign lesion. Now, a doctor is in dilemma. What he should do? Shall he take biopsy to confirm the diagnosis, or he should wait and watch? In both the situations, there is a ticking time bomb lurking in the mouth. Because if it's a malignant growth, you didn't take biopsy in time, patient will ultimately develop into oral cancer. If it's benign, fortunately, nothing may happen to him. But eventually, that benign condition may turn into malignant if the patient continues chewing tobacco or erica nut. Now, barriers to early detection of oral precancerous lesions. What are those? Patient factors. Access to healthcare. Access to healthcare is the most important factor which prevents patients seeking medical help. Reluctance to seek an oral examination by a healthcare worker. People are not ready to open their mouths and get themselves examined. Like Dr. Mina from Iraq told us that they are afraid of getting diagnosed of oral cancer. Sometimes there is a denial of screening examination of suspicious lesions. They don't want to get examined. I have come across plenty of patients who had a large ulcer in their mouth, on tongue, gingiva, palate, floor of the mouth for a long duration, maybe days or months, but they don't want to come to a doctor for examination because they are afraid of getting diagnosed with oral cancer. Practitioners factors, medical practitioners factors, absence of knowledge. It is surprising, but there are people, there are dentists, there are dental specialists who are not knowledgeable about oral precancerous lesions. No high suspicious index. They never think that this ulcer, which is not healing from last 10 to 15 days, could be malignant. They don't have high suspicion index. They think it's okay. You take vitamin B complex for 10 days, you will be fine. No proper instrumentation available. They don't have proper instrumentation. They don't have proper training. They don't have proper knowledge. And secondly, they may not have proper specialists available to them who can diagnose the oral precancerous lesions. And therefore, these four factors from practitioner side and these three factors from patient side, they are the barriers for early detection of precancerous lesions. Now, addiction to smokeless tobacco, it doesn't affect only your health. It has a large scale effect all over society. Complete society is getting affected. It has a health effect because you can die, you can have addiction, you can have cancer, you can have economic impact because patients are spending a lot of money after they're satisfying their habits. Social effect because the women are also consuming erica nut and tobacco. Environmental effect also is there. And finally, demographic effect. You will be surprised to know that every hour, 16 people in India are dying of oral cancer. So you can imagine how much demographic, and which are preventable. These deaths are preventable, but still nothing is being done about it. Now, factors associated with consumption of erica nut and tobacco by young. What factors are being associated with consumption of erica nut and tobacco by younger generation, children? Earlier, when I was student of maxillofacial surgery in Bombay, we were told that oral cancer you don't find generally before age of 40 to 55. But today, I have seen, or many of the surgeons are saying, oral cancer cases in the 20s. Submucous fibrosis has been diagnosed in pediatric cases. Why? Because a child, 3 years, 4 years, 5 years, 10 years, he starts chewing tobacco and erica nut and lands into precancerous lesion by the time he's 20 years old. And then, if he continues with the habit, by the time he's 25 to 30, he will develop oral cancer. And you know what can happen once you develop oral cancer. The level of knowledge, both children and parents are not aware that erica nut and tobacco habits are dangerous to their health. Household environment. Children living in joint family, which are very common in India. Few family members have habit of gutka, pan or supari. Children who are staying in such household procure smokeless tobacco products for older family members. So they get exposed to this kind of smokeless tobacco products like gutka or pan parag or pan masala at a very younger age. Peer pressure. That means a child, suppose he gets some kind of health issue, the father or mother or grandfather will say, okay, you take this tobacco or erica nut and then possibly you'll be fine. So they feel that it's a kind of an experimentation for a child. SLT products are readily available at roadside and near residency. They are freely available. You walk on any street in India, every alternate shop is selling pan parag and pan masala. They have money available to children, 1 rupee or 2 rupees or 8 annas to buy this kind of products. Because of low cost, SLT products are available with the smallest amount of pocket money. Even 1 rupee satisfies the need of a SLT product to a children. The parents supply money and they are aware, they know that the children are spending money after buying SLT products, smokeless tobacco products. But since they are not aware of it, they don't bother. Now this is 90% of smokeless tobacco users live in 11 countries of the world. These are the statistical data. India, we have got 7.4 million people who are using SLT products. Bangladesh, Myanmar, that means Burma, Pakistan, even USA, 9.6 million, China, 4.1 million, Indonesia, 3.2 million, Nepal, 2.7 million, Madagascar, 2.6 million, and Germany and Uzbekistan, 2.4 million each. So 90% of SLT users are concentrated on these 11 countries. Totally, it is believed that there are around 600 million people around the world who are habituated to SLT products. This publication was published by Ajit Auluk from Canada, and he said these are the publications from 1985 till 2002 in which all these publications showed the ethnic group staying in these countries being affected by pan parag or pan masala or erica nut betel chewing habits, like Canada, United Kingdom, Germany, Australia, France, South Africa, and USA. Now the problem is, you go to any American university or university in UK or other Western countries, and you talk to them about oral submucous fibrosis. They say, oral submucous fibrosis is not our problem. It is your problem. So closest thing to invisibility is to believe that this problem is not my problem or our problem. It is someone else's problem. And this attitude by Western countries or countries from Western Hemisphere are causing or are going to cause a lot of problems. Although warning bells have already begun to ring in US and other European countries for so much, ignorance and indifference, Although warning bells have already begun to ring in the US and in other European countries for much of the Western world, ignorance and indifference to this widespread addiction are attributed to policymakers in different attitudes. Western dental and medical literature are silent on this subject because scarcity of cases of oral submucous fibrosis. Relatively recent publications on oral precancerous lesions fail to include oral submucous fibrosis as critical oral precancerous lesions. Now I am listed three publications, and these are not written by some small time person. These are world renowned oral pathologists, oral medicine specialists. And they never bothered to talk about oral submucous fibrosis because Americans don't get submucous fibrosis, Britishers don't get submucous fibrosis, Germans don't get submucous fibrosis. But what about future? After 10 years, 15 years, 20 years, they are going to have same problems as India and other South Asian countries are suffering. Francis Lozada Noor, we've got Crispin Scully. I don't have to introduce Crispin Scully. He passed away recently, some time back. He was a well-known, internationally famous oral physician, but still he never bothered about mentioning about oral submucous fibrosis. And another important thing, whenever people talk about tobacco, they always talk about cigarettes. They never talk about smokeless tobacco. You read any publication, may be by medical professional, dental professional, or industrial, or government, or CDC, or WHO, or any healthcare agency anywhere in the world, they restrict their talk to cigarettes. They don't bother about smokeless tobacco. It is indeed surprising that most people in general and healthcare workers in particular equate tobacco to smoking, and no consideration is given to SLT use. This is important because some public health authorities see potential role of SLT in tobacco harm reduction. Can you imagine? There are some healthcare workers who believe that if you want to stop smoking cigarettes, you can use SLT tobacco products. That means you stop smoking and start chewing tobacco. Now, do you have answer for this? Because people think SLT products are just simple, harmless products. They don't know that even SLT products are equally, if not more harmful than cigarettes. Now, global prevalence of SLT of use among youth and adults. This is a global statistical data. More than 300 million adults in 70 countries across all WHO regions use smokeless tobacco. The largest share, 89%, is in Southeast Asian countries. That means India, Pakistan, Burma, Nepal, Sri Lanka, China, all these countries. Among youth and adults, males generally show higher prevalence of use than females. However, among adults, use by women is similar to or greater than use by men in some countries. In some countries, women are using more SLT products than men. All 6 WHO regions reported a prevalence greater than 10% among boys and men. Now, we will just very briefly go through some of the SLT products or the role of SLT products in these regions, like African region. Now, Africa region consists of 46 countries, and they are divided into Western, Eastern, Central, Northern. And second is, what are the key facts of African region? 13 million women use tobacco products, including chewing tobacco and snuff. 13% of young adolescent girls use tobacco products. This is in African countries. About 22,000 women die every year from tobacco-related diseases which are preventable. 22,000 women per year. Between 2002 and 2030, tobacco attributable deaths are projected to double in low and income countries, that means LMICs, including Africa. Now, this is African region. This is a bar diagram showing you the incidence of tobacco consumption or SLD consumption in various areas, various countries like Congo, Namibia, Togo, all this. Now, what are the final key findings? Prevalence of SLT use varies across countries and geographic areas within countries. For example, national prevalence was as high as 28.3% for women in Mauritania and 22.6% men in Madagascar, and as low as 0.2 for men in Zambia and 0.5 for women in Nigeria and Zimbabwe. Smokeless tobacco products are sniffed, chewed, sucked, or applied to teeth and gums. Customs associated with SLT use vary widely across different parts of African region. Data suggests a widespread perception that snuff possesses medicinal properties, such as relief of headache, toothache, or sinus problem. Very little data exists on the health effects of ST in this region. Although existing data for some parts of Africa suggest oral ST use is associated with increased risk of oral pathologies, increased blood pressure, nasal snuff is associated with an increased risk of nasopharyngeal cancer and respiratory disease. Then we come to Eastern Mediterranean region. There are 23 countries extending from Morocco to Pakistan. Of course, Pakistan is not part of Eastern Mediterranean countries, but WHO has considered it as a part of Eastern Mediterranean country. And these are the statistical data or the bar diagram of SLT use in Eastern Mediterranean countries. Starting, Bahrain has got 19.9% in males, 10.5% in females. Libya has got the least 2% in males and 2.5% in females. What are the key findings? Data on ST use are not available for most countries in Middle Eastern region. Smokeless tobacco is widely consumed in few countries, including Yemen, Pakistan, and Sudan. While ST use has been documented among women, prevalence is substantially higher among men than women in this region. Most frequently used products in this region include tumbak. Tumbak is like a tobacco product. Shamma, that's in Yemen, they call it shamma. It's also part of tobacco product. Pan is like betel quid. It's very common in Pakistan and India. Nas means they inhale through their nose. It's very common in Pakistan and Iran. Specific toxicity and nicotine profiles are only available for Nas and tumbak. Tumbak has been reported to have highest level of nicotine and TSNA ever measured in tobacco products, the highest level of nicotine and TSNA. Studies in several countries in this region have documented associations between precancerous abnormalities, oral cancer, head and neck cancer, and use of tobacco, shamma, nas, and pan. All these four products, SLT products, are known to have relationship with oral cancers, precancerous abnormalities, and head and neck cancer. Then we come to European region. There are about 53 members, and European Union also. Will not go into details of the geographic data. And this is the, again, bar diagram showing you the incidence of SLT products in European region. Norway has got highest, males 80%, 18%, females are 9%. Netherlands has got minimal 0.3 in males and 0.1 in females. And what are the key points? European regional data on tobacco use are primarily focused on smoking. As I told you earlier, someone else's problem. European countries believe that submucous fibrosis or anything related to smokeless tobacco is not our problem. European regional data on tobacco use are primarily focused on smoking. Limited information is available on smokeless tobacco. You have to underline this line. From the available national evidence, prevalence of ST use among adults varies from 0.1 in Latvia to Switzerland to 17% in Sweden. Men have higher rates of current use of these products than women, with 17% of Norwegian men, 22.5% of Uzbek men, and 26% of Swedish men reporting ST use. 26% of Swedish men are using smokeless tobacco. Subnational survey shows higher ST prevalence among specific groups. That means some group of migrants who have migrated from Southeast Asian countries to these European countries, like Bangladeshi women, they show higher use of ST products. Europeans use variety of ST products. They have got moist snuff or snus originated from Nordic countries of Sweden, Norway, Finland, Iceland. And sometimes range of products are imported by use by communities of Southeast Asia origin, like Indians, Pakistanis, Bangladeshis, Sri Lankans in UK. They import these products and use it for their personal purpose. OK is a home to largest South Asian community within Europe. To varying degrees, the members of these groups have brought their traditional ST use to practices with them from their countries of origin, which have the highest global prevalence and negative health impacts. So all these migrants who are now migrated to UK, USA, and other Western countries, they carry along with them their habit of smokeless tobacco and continue their habits in these Western countries. Then we have got regions of Americas. It has got 35 countries and it's a large area. And American regions, we have the Barbados are showing 11.5% in men, 8.2, while Costa Rica is showing the minimal product. Now, what are the key findings in region of Americas? Among youth, reported current ST use range from 1.8% in Canada to 9.8% in Barbados. Smokeless tobacco use was more prevalent among boys than girls in nearly all countries and localities. While most significant sex difference in United States, that means in United States, boys are using SLT more than girls. Prevalence use of ST among boys range from 2.6% in Canada to 11.5% in Barbados. And among girls, it was 0.8 in Canada to 8.5 in Jamaica. For adult men, the highest reported prevalence of use was in United States was 7.1%, while use by adult women was highest in Haiti, 2.5%. Two types of snuff are manufactured and used in the United States: moist snuff and dry snuff. Moist snuff is by far the most widely consumed type in the United States and Canada. Loose leaf, plug, twist are the three types of chewing tobacco sold in North America. SLT products are produced by large cigarette companies and have been marketed to smokers in situations where they cannot smoke. Imagine, large cigarette companies are manufacturing SLT products and they are advising the Americans that if you cannot smoke, then use SLT, as if SLT is safer than cigarette. Regulation of ST products in America is generally weak or absent. There is no regulation on SLT products. Brazil prohibits sale of ST products by law, but they still available in some countries. Compared with cigarettes, ST products are taxed at a lower rate, have weaker warning labels, and fewer cessation supports throughout the region. Then we come to Southeast Asia region. There are 11 countries, and this is the key findings. Prevalence of HT use among men is highest across most of the Southeast Asia region, varying between 25% to 51% in 5 countries, but less than 2% in Thailand. Among women, HT use is high in India, 18.4%. Bangladesh 28%, Myanmar 16%. Prevalence is also high across the region, equivalent to cigarettes among youth aged 13 to 15 years. This region is home to over 250 million ST users aged 15 or older. Rural users in India and Bangladesh make up to 80% of total ST users in the world. Imagine, rural users make 80% of total ST users in the world. Smoking remains more common than ST use in Indonesia, Thailand, Bangladesh, Sri Lanka, and Nepal. But ST use predominates in India and Myanmar among men. So men are using more ST products than they smoke cigarettes. In India, most common forms of ST use are tobacco with lime, that is khaini, or what is known as gutka or betel quid. Betel quid is typically freshly prepared by the user or a vendor. Pan masala and gutka have become increasingly popular as alternative to traditional betel quid. They are manufactured on an industrial scale and sold in dried form. Incidence of oral and pharyngeal cancers is highest in Southeast Asian regions, countries compared to rest of the world. And this high rate is being attributed large part to ST and areca nut use. Historically, only 10% to 15% people with oral cancer in India had diagnosed when their cancer was in early stage or localized stage, which results in poor survival rate. You'll be surprised to know that oral cancer incidence in India is 50%. And in some states like Gujarat, it is more than 70%. That means if there are 100 cancer patients, 70% of the patients are having oral cancer. These are again, a bar diagram showing you incidence of SLT use. And finally, we come to Western Pacific region. And what are the key findings? Prevalence of data used in this region are scant. Western Pacific region, fortunately, is not very much addicted to SLT use. Few countries with ST use data, the rates vary from 20 to 4% among men aged 25 to 64 years in Micronesia and 0.3 among males older than 15 years in Vietnam. In some countries, Cambodia, Malaysia, and Vietnam, rates of ST use are higher in females than males. Forms of ST use involve areca nut, betel quid, with or without tobacco. Although tobacco is not traditionally added to areca nut, betel quid in some countries, current policies and interventions vary across countries in this region. Some countries have instituted ban on ST products like Australia and New Zealand, bans on ST manufacturing like Taiwan, bans on ST importation like Japan, Hong Kong, Singapore, and Taiwan. However, these bans may not affect the use of areca nut, betel quid with tobacco, which sometimes obtained from cigarettes. The cigarette is open and tobacco is taken out from that cigarette and use it with pan. Besides, some of these bans remain weak because they do not prohibit importing ST products for personal consumption. These are again the bar diagram showing you the SLT consumption in Western Pacific region. Micronesia is 26.5% in males and 21.7% in females, while Brunei is having the minimal percentage. Now, do we have any strategies to control this SLT or tobacco control? Can we have vaccine like we had vaccine for COVID? I have prepared this vaccine, or actually this is from Nebraska University. They have suggested that you have a 100% smoke sip policies. It's one part, 25%. Then your tobacco price increase. You increase prices of tobacco products so much that people cannot afford to buy it. Then cessation access. You have to train your healthcare workers, you have to train your people, you have to talk to them, educate them, and hard-hitting media campaigns. If you combine all these four together, you can have a very, very effective vaccine against tobacco habits. Four key strategies emerged as an evidence-based approach to tobacco control. I hope some of you who are listening to this talk will think about this in future and try to develop this kind of vaccine. Well, I want to thank you very much. Oral submucous fibrosis, it is not because things are difficult that we do not dare. It is because we do not dare, they are difficult. We don't try to control tobacco habits. That's why they are difficult to control. If you try, they can definitely be controlled. My contact details are given here. My email ID is drnanavati1@gmail.com and my phone number is 281-210-4347. Thank you very much.